So thank you, Maria, and I would like to thank you especially for the privilege of being our coordinator, because it has been really a pleasure, and I would like to thank Aquas and the extraordinary team that Aquas put in place to support us. Rossana Holman patiently helped us and supported us to transform the challenges into a push to overcome our limitations. We have a lot of limitations in the implementation of antimicrobial resistance. So I am an endocrinologist by training. I have a background in basic science. So for me, the challenge of antimicrobial resistance is really special, because I see the world through these little plasmids that transfer genetic resistance to antimicrobes. Our hospital is the largest facility in southern Italy, bridging care services with research and also training and education. And we have 750 beds and provide many outpatient and inpatient services through a multi-site building. We have 25 buildings. And that is a logistical challenge for any implementation we usually undertake. You have already had a look, you already had an overview of the process that we implemented in RaDAR, and we focused our needs identification with an interdisciplinary approach that brought us to focus on rapid detection of common microbes and strengthening an integrated and smart management of antimicrobial resistance in our hospital. We carried out this double consultation, engaging small companies, small and medium companies on our territory, and we established an interdisciplinary network of experts and stakeholders to finally define our demand. Being a university hospital has an advantage that is easily accessible, quote unquote easily, to especially clinical experts across a number of specialistic areas, but we also involve the nurses, because nurses play a very important role in implementing innovative approaches to antimicrobial resistance. We had some struggling interaction with the digital experts, because we have a number of data system and data flows in the hospital that lock in the possibility to integrate innovative solutions. So that was a struggle. We have been involving intensive care units for adults and neonatal care units, because they have an issue with antimicrobial resistance. And last but not least, we have administrative staff. So I have to say, I was really important to hear from Ismea that there is a platform to build the capacity across administrative staff, because this was, unless it was for the strong will of a couple of people in the administrative staff, it would have been impossible to overcome the constraints of the Italian digital platform to publish the tenders. Because in our case, for example, this was a very simple problem. We had 150K lot. This is under the threshold for publishing an open bid. And we needed to do a targeted appointment. But we preferred to open the consultation. And this blocked the system digitally. So it was impossible to retrieve the first effort, administrative effort. We had to redo the entire procedure again, agree with the officer that as we had only one company interested, we could do a direct appointment, and then we lost like 6-8 months, I think, just to give you a taste for the complications. So the results of the needs analysis in our hospital setting focused around the 3 pillars. The first pillar is the quick identification of common infections. And this was very important to improve prescribing of antibiotics. The second core cluster was around the monitoring of antibiotic-resistant infection, and this was done through the integration of data with the hospital system, and we could not achieve this, but at least we managed to share the data of the pilot across the different clinical clusters thanks to the platform. And we strengthened the surveillance system in the hospital. And last but not least, we implemented an innovative approach to prevent hospital-acquired infection in the hospital. This is a very simple journey of infections management in our hospital. We focused on inpatients, so the journey starts at the outburst of clinical signs and symptoms of infection that following which we implement a few rapid tests that we have available at the hospital. Then the treatment is either empirical or deferred, depending on the number of tests that are requested by clinicians. And then in the meantime that the microbiologist comes back with the results, we wait or we, as I said, prescribe empirical treatment. Then the results come back and the therapy is revised and finalized, and then eventually there is a control. Our call for tenders reflects the three priority blocks that I showed before. First of all, the point of care, so a system for accelerating the detection of the type of infection, common infection, an integrated clinical decision support system that should be rooted in the surveillance results that are monitoring the hospital, and then the interoperability of the IT system. The KPIs have been, you have seen already the key outcome, and the KPIs we picked are in line with the aim of improving management of patients, pathogen, prescription of antibiotic of the sample, and also improving the general acceptance of the innovative solutions working on usability and acceptance. So we have been focusing on the optimization of prescription of antibiotics and improving the timeline of the diagnosis. Now, I don't know if there is a connection from Kalion, but yeah. I would like to thank Kalion because they have not been only the provider of the solution, they have been a partner for us because it takes more than a provider to address this kind of complex implementations, and they've been flexible enough to adapt to the different groups that we were involving for the implementation. So I don't know if there is anybody from Kalion connected.
Thank you, Professor Ilario. I'm here. I'm Andrea from Kalion, Andrea Granata from Kalion. Can you hear me?
Anyways, Kalion Antimo is the platform, the integrated platform.
Can you hear me?
Yes.
Okay, good. So they're better than me at explaining the solution. Hi. We cannot hear you, and now we see you, but don't see the slides anymore.
Can you hear me?
Yes, now we hear you.
Yes.
Do you want to share the slides from desktop, maybe?
Thank you, Professor Ilario. Can you share the screen? Because I
cannot. So.
Okay. Well, I will share the slide from Kalion perspective. Can you see the screen?
Yes.
Thank you, Professor Ilario. I will now briefly introduce Antimo from Kalion perspective, focusing on the value created together within the RaDAR-PPI process. The key point is that Antimo should not be seen only as a software platform. In this project, it was framed as an operational tool to help transform microbiology and rapid diagnostic information into decisions that can be used by clinicians, microbiologists, infection control teams, and hospital governments. The platform was developed around three main clinical objectives. The first is to monitor antimicrobial resistance in hospital and community settings. The second is to support clinicians with timely and contextual information, so that data become usable at the point of care. The third is to guide antibiotic choice through evidence-based recommendations, supporting antimicrobial stewardship without replacing a clinical judgment. The 4 modules shown here reflect this logic along the care pathway. The dashboard gives visibility on AMR trends and risk areas. POCT integration brings rapid test results into the workflow. Guidelines support treatment choices and prescribing quality. The Learning Hub helps disseminate protocols and sustain adoption over time.
We cannot hear you anymore. What did you do in the technician?
For us, the co-creative value with Unina was precisely this, moving from isolated technological components to a shared workflow connecting rapid detection, surveillance, and stewardship. I will now go into the first module, the dashboard.
In projection mode, you are not...
Sorry.
That's fine. No.
Can you see the screen?
Yes, but you are again not projecting the slides.
I think I have a problem with PowerPoint.
But I see the slides and PowerPoint.
Okay, thank you.
Oh,
Okay, the first module is the dashboard. In the context of RaDAR and of the Unina case, this module is important because rapid detection and microbiology data generate value only if they can be read, interpreted, and shared across the organization. The dashboard gives real-time visibility on resistance profiles and on the spread of resistant pathogens across different settings. It allows the hospital team to monitor AMR patterns, identify high-risk areas, and follow trends over time. The interaction with Unina helped us understand how important the level of granularity is. Data must be available not only as general epidemiology, but in a form that can support operational decisions. For example, the same information can help understand what is happening in a specific ward, prioritize attention on specific organisms, or measure whether an intervention is producing an effect. So the key message is that Antimo makes microbiology information easier to read, easier to share, and easier to act on. The next module brings this logic closer to rapid detection and point-of-care testing. The second module is the integration with point-of-care testing. This is the area most directly connected with the RaDAR challenge of rapid detection. Antimo supports workflows for rapid identification of pathogens and currently includes tests such as flu, pulse SARS-CoV, Clostridium difficile, Legionella, and RSV. The value here is not only that the test is passed, the value is that the result enters a structured clinical workflow. The platform supports registration, execution, and result handling, helping users follow a consistent process and reducing manual transcription. Another important point is interoperability. Antimo was designed so that additional rapid detection systems can be integrated through interoperability standards. This is relevant for future scenarios because the rapid detection landscape will continue to evolve. A hospital platform must be able to absorb new diagnostic technologies without forcing the organization to redesign the whole workflow. From Kenyon perspective, one of the strongest lessons learned with Unina is that rapid testing creates maximum value when it's connected to action, timely clinical decisions, infection control measures, and structured reporting. Once diagnostic information is available, the next step is to support appropriate treatment choices. The third module is guidelines. This component helps connect diagnostic information to treatment decisions. Starting from the diagnostic suspicion, Antimo can present recommended treatment options and make clinical guidance more accessible at the bedside. This is particularly relevant for antimicrobial stewardship. In many organizations, guidelines exist, but they are not always available in the right format at the right time or within the clinical workflow. Antimo helps bring those recommendations closer to the moment of prescribing. It also allows prescribing behavior to be compared with guidelines, supporting audit, quality improvement, and reduction of inappropriate antibiotic use. A key design principle is that the platform supports clinicians but does not replace them. The objective is to provide structured and contextual information, leaving the final decision to the responsible healthcare professional. This is important in a complex institutional environment such as UNINA, where antibiotic decisions depend on patient condition, local epidemiology, available diagnostics, and stewardship policies. The guidelines can also be customized at national, regional, or local level. This makes the module adaptable to different hospitals, departments, and evolving stewardship strategies. Finally, adoption and sustainability require structured training and protocol dissemination. The last module is Learning Hub. This is particularly important when we speak about PPI and co-created value, because innovation is not complete when the technology is installed. It becomes effective when people understand it, use it, and integrate it into their daily routines. The Learning Hub provides a centralized environment for procedures, protocols, guidelines, and training materials. Content can be uploaded, updated, and organized in one place, so that teams have access to consistent and current information. It can also be delivered by role or by operational unit, which is useful in a hospital where clinicians, nurses, laboratory staff, infection control teams, and managers have different needs. The module also allows training progress to be monitored. This is relevant for antimicrobial stewardship because stewardship is not a one-time intervention. It requires continuous alignment, dissemination of protocols, and enforcement of good practice. For Kalium, the main value of the RaDAR-PPI experience was the opportunity to co-design with UNINA a practical bridge between rapid detection, AMR data, stewardship decisions, and organizational adoption. Antimo is the digital layer that helps make this bridge visible, measurable, and usable in daily clinical practice. This closes the Antimo overview and connects back to the wider UNINA and RaDAR lessons learned narrative.
So if we can go to the next slide and maybe I can I? How does it work now? Okay, so this is the way the service process looks now. Essentially, what happens after admission to the hospital, the POC kicks in and supports clinicians for early detection of common viruses so that the differential diagnosis with bacterial infection and viral infection is immediate. And that is done just before the samples are drawn and sent to the microbiology lab. And there have been a number of positive impacts of this integration, especially also because the Antimo solution, as you have seen, has the opportunity to be flexible, modulated to support clinical decisions. Just a step back to the overview of the implementation of the contract. We have been implementing our activities through 3 phases. The first one has been very intensive, and it involved the change management. You will see how hard it can be to put them together when I show you which departments were involved. And the multi-building localization of the different departments was a further complication. So we needed to have differential on-site adjustments and testing acceptance. First of all, conceptual acceptance, because at the end of the day, the nurses were at the forefront of the implementation of the POCT and of the surveillance system. So the change management was very successful. For once, the technologies didn't let us down. They were very effective. The installation of the system in the 6 planned departments was on time. The configuration and the functionalities of the POCT devices was done also timely. And the access to the platform was ensured to all stakeholders of the different operators. And finally, we could demonstrate before the pilot began the workflow of the activities according to our RaDAR implementation. So the units involved in the study were adult ICU, geriatrics, infectious disease unit, neonatal ICU, pediatric surgery, And then we replaced the neck surgery department with the internal medicine of another, because that surgery could not do the project. So we had the availability, the opportunity to involve a community hospital. And this community hospital was from local health agency Caserta, Marcianise Hospital, and they also have the emergency. So that was especially interesting because the internal medicine colleague was using the POCT to titrate the admission from the ER. And that was really important because it allowed to prevent the outburst of flu epidemic in the inpatient rooms, because they could separate and isolate the patients immediately. And also, I was talking to her yesterday. We are going to retrieve the data about the length of stay in internal medicine, and it seems, I don't want to be too optimistic, but it seems that the length of stay is reducing compared to the average of the case mix of the same hospital from the previous year during the epidemic. The rapid test that the clinician chose, because this was the results, so you have to understand that to arrive to this, to an agreement for the 4 tests to make, it took us many meetings, and when you are waiting for a clinician to come from the ICU, the meeting is basically an open door, because each one of them shows up at a different time. So this was very pragmatic, because they have emergencies, they have things that happen while they are moving to come to the meeting. So you have to be very flexible, but they really wanted to do it. The nurses were very involved. So in the end, they agreed to do respiratory syncytial virus, RSV, Legionella, A and B flu, SARS-CoV-2, and Clostridium difficile for for gastrointestinal infections. So these are the tests we purchased. Then there has been a distribution between the different units. And at some point, we internally shuffled some tests that were not being used during the flu pandemics. We reshuffled some lots of tests to the internal medicine of the emergency, because that's where they were most needed. And we decided to give them the opportunity. The training module was focused around the 3 main content. And the first part is we actually took the opportunity to recap a bit with all stakeholders what's the relevance of antimicrobial surveillance and how the RaDAR project could be useful for them. This was very important to motivate them to stay engaged. The second part was we took the opportunity to revise the hospital procedure in terms of infection control and prevention of antimicrobial resistance, and we discovered that some of them needed updates because it had not been updated. So we involved the clinical lead of the hospital. So it was a very interesting opportunity. And finally, we landed on the real teaching of the integrating of the point of care into the clinical practice. So we had to decide where in each of the setting of the different clinics the tool should be placed, who should be in charge, and because this was also kind of a conversation between microbiologists and nurses, because when nurses don't have it in their, it's not their job to do the POCT, but microbiologists are not enough. We have like 4 or 6, so it's impossible for them to take over the control of the POCT in the different clinics. So they agreed it was like a sort of informal hub and spoke model. So the responsibility was of the microbiologists and the deployment was of the nurses. So they did, that's why it was important. They trained together. And this is still informal organizational change. Actually, the changes in the hospital are formal only where they end up into the performances of the hospital. And if I have to say, we are still very far from reaching a change in the performances for this. But at least in the daily practice, this is done. As I said, there was a good participation to the training. We had a total of 47 participants in presence. I wanted the training to be in presence. And mostly there were clinicians and nurses, but also biologists and other people, some from my team and some others from the communication. This is the research protocol. It's much simpler than it looks like. And basically it's a multi-center study between our hospital and Marcianise Hospital, the one in Caserta province. It's a single-arm study targeting patients hospitalized with a clinical suspicion for infection. The intervention is the RaDAR system, and the outcomes is the evaluation of primary and secondary endpoints that are focusing on the effectiveness of the new system to detect specifically the targeted infections. And the secondary objective is the time that it takes in comparison to the time of the routine microbiology testing. We enrolled 103 patients, and the age was between 0 and 95 because we have the neonatal the neonatal intensive care unit, so we had some newborns. And we have an average age of 50, and actually the 57 actually, and the distribution between sex is pretty balanced. Most of the patients are admitted from their home, from the community. We have part of patients that have been transferred from other hospitals. Some of them are born in the hospital, and some of them are from nursing homes. There was one patient coming from jail. We deliver services for jail patients, and I wish I could have extended the study much longer to have a subset for this population, because I think that jails are a really serious hotspot for antimicrobial resistance and deserve a better attention. Here you see the time. So first of all, no, here is the sensitivity and specificity. So the test had very few, if none, false negative, which is very good. Just a few false positive, and this places the test as being very effective, because false positive is okay, false negative would have been a problem. So we have 95.8 specificity rate, and this is true for flu, for SARS, Legionella, RSV, and Clostridium. And this is a comparison of the time. So, you know, there is a big average of time, of the time it takes the microbiology lab to give us back the results. It depends a lot on we have a chronic shortage of professionals in our region, because we have been living a contingency measure since the last 20 years. This means that human resources turnover has been frozen for 20 years. This means that we are chronically understaffed. So when I compare, I've been doing a comparison between number of beds and number of human resources, and we more or less have 1/3 of the human resources you have in your hospitals. I've been doing comparisons with Germany, Austria, Spain. So we are totally understaffed, especially in terms of administrative personnel and nurses. So this is why also you see the average time to have back result is 13 hours. It's a long time, but it's not, it's the average, because sometimes you have a festivity, so you do not have enough people to cover the shift, and there are a number of reasons. So but anyways, the median of time to obtain the results from the POCT is 4 hours. The average of the microbiology is 13, so the math is very simple. So it's very convenient to have the POCT, and is a very strong improvement. And the number of patients that are isolated, out of 18, there was 1 false positive and 17 were isolated, which is very good. Now, if we look at prescription. So in the first block, you see we enrolled 103 patients. 60 of these 103, according to WHO guidelines for appropriate prescription of antibiotics, I'm finished. They should have been treated. But using the POCT, we only prescribed antibiotics to 40 of them, and this is very good. And of the patients with a positive POCT result, 60% did not receive antibiotics. Now, we are not, the limitation is that we did not consider additional diagnostic tests, but the trends are very, very interesting. This is usability and satisfaction are very good. Actually, everybody liked the test. The only negative expectation is the problem, because when we started, we expected to integrate with the hospital record, and this would have allowed us to target AMR and MRDO, but we couldn't do it because we were missing a number of pieces of information, and so we could not do it. But overall, this is a very strong, good, positive results. And I just had one last slide that I don't see, that was about what comes up next. We are planning to integrate in the local health agency in Marcianise the digital solution, because they have an in-house IT system. So they are not, do not undergo the lock-in system from the companies handling the data flow. And we would like also to customize the implementation of the RaDAR solution on surgery, for the wound healing, and also for the handling the devices of critical patients that are the two hotspots, and also to strengthen the integration of the training and education package with the bundled documents, because these checklists that are used by nurses are, in the end of the day, the terminal. What is really useful for them, you can print them, put them on the wall, link them to QR codes to obtain immediate suggestions on operational guidelines, and this is what we are planning to do, and maybe look for funding also in national cause. Thank you so much. I don't know if there are questions.